Welcome back to the deep dive. Today we're really getting into an important topic, especially if you're revising or just need a solid handle on a tricky condition.
Yeah, absolutely. We're talking Pneumocystis Pneumonia, often just called PCP.
Exactly. And we've pulled together some pretty comprehensive revision notes. The plan is to cover everything, from the basics right through to management and prognosis.
hmm We want to pull out the absolute must-know stuff,
Yeah.
the high-yield information, and hopefully make it stick for you. Think of this as your focus guide to really understanding PCP.
Right. So we'll cover what it is, the cause, risk factors, how it actually affects the body, what else it might look like, the differentials, who gets it, how patients present, diagnosis, treatment.
What to expect, potential problems, the whole picture, really.
Okay, sounds good. Let's dive straight in then. What exactly is pneumocystis pneumonia?
So fundamentally, PCP is a serious lung infection. It's caused by a fungus, a Pneumocystis jirovecii.
Jirovecii, okay.
And the key thing here is that it's an opportunistic infection. So in someone with a healthy immune system, it usually doesn't cause any trouble.
But if your immune system is weakened,
Exactly. That's when it grabs its chance and can cause really significant illness. You might still hear the older name sometimes, Pneumocystis carinii pneumonia.
right, PCP from Carini. So jirovecii is the current name for the one affecting humans.
That's it. And this organism, Pneumocystis jirovecii, it's a bit unusual.
How so?
Well, it sort of sits between being a fungus and a protozoa. It's a unique single-celled organism, a eukaryote.
Interesting. And it's a big deal in certain patient groups.
Huge. It's actually the most common opportunistic infection in people with AIDS. Finding PCP in someone with HIV is actually an AIDS-defining illness.
Wow. Okay, so the diagnosis itself carries that weight.
It signifies a major decline in immune function for that patient. And it's serious. Without treatment, it can cause severe respiratory problems and potentially be fatal.
Does it spread outside the lungs much?
Thankfully, no. It mostly stays localized to the lungs. Extrapulmonary spread is pretty rare.
Okay. So the main message is serious fungal lung infection primarily hits the immunocompromised, needs timely treatment and prevention.
Precisely.
Got it. So that's the what. Let's talk about the etiology.
Yep.
The why. What's the specific cause again?
Right. The culprit is that fungus we mentioned, Pneumocystis jirovecii. And always remember, it's opportunistic. It needs that weakened immune system to cause disease.
And how do people actually get infected?
It's thought to spread through the air. You basically inhale these tiny fungal spores.
Spores that are just around.
Yeah, the fungus seems to be pretty common in the environment. But again, for most people with healthy immune systems, breathing it in doesn't lead to illness. It's just waiting for that opportunity, you could say.
Right, the weakened defenses. Which leads us perfectly into risk factors. Who is most likely to get PCP?
Well, the number one risk factor, as we've said, is a compromised immune system. But we can be more specific. People who are HIV positive are a major group, especially, and this is a key number, if their CD4 count drops below 200 cells per cubic millimeter.
Below 200. Got it.
Also, having other HIV-related issues like oral thrush, unexplained fever, or a prior AIDS diagnosis increases the risk too.
Makes sense. But it's not just HIV, right?
Not at all. Other big groups include people taking immunosuppressant drugs, think steroids, or drugs used after organ transplants or for autoimmune conditions.
Okay, so transplant recipients.
Yep.
Wow.
Also, patients with blood cancers, hematological malignancies, people with certain connective tissue diseases like rheumatoid arthritis, particularly if they're on those immunosuppressants.
So quite a broad range of immunosuppression types.
Indeed. And also think about congenital immune problems, things people are born with like SCID, thymic hypogammaglobulinemia,
Right.
and perhaps less obviously severe malnutrition, especially in combination with HIV. And having pre-existing lung disease might slightly increase susceptibility as well.
That's quite a list. Is there an easy way to remember the main groups?
There's a little mnemonic that might help. Think, I'm H.O.M.I.E.S. I for immunosuppressed generally, M for malignancy, specifically of blood cancers, H for HIV with that low CD4 count, O for organ transplant, and T for treatments like steroids.
I'm HO2. That's useful. Okay, so now we know who's at risk. What actually happens inside the lungs when pneumocystis takes hold, the pathophysiology?
So the infection sets up shop primarily in the alveoli. Those are the tiny air sacs where gas exchange happens.
Okay.
The fungus being there triggers inflammation. And that inflammation messes up the normal process of oxygen getting into the blood and carbon dioxide getting out.
And that inflammation causes damage.
Yes, the lung tissue itself can get damaged. You get fluid building up in the air spaces, inflammatory cells accumulating. It all contributes to blocking gas exchange,
Leading to?
leading to hypoxia, low oxygen levels in the blood.
Mm-hmm.
And if it's severe enough, it can progress to respiratory failure.
So the lungs just can't do their job.
Pretty much. Now, the exact molecular mechanisms aren't perfectly understood, but it seems to involve a poorly regulated immune response to the fungus itself. It primarily causes problems in people with defects in their T-cell immunity.
Right. The T cells aren't controlling it properly. Okay. Now, those symptoms, shortness of breath, cough, sound like they could be many things. How do we differentiate PCP? Let's talk differentials.
You're absolutely right. The symptoms overlap significantly with other lung conditions. So the differential diagnosis list is quite long.
Okay, what's on it?
Well, you've got to consider other types of pneumonia, bacterial, viral, other fungal lung infections too, like histoplasmosis or invasive aspergillosis.
Right, other infection.
Tuberculosis is a big one, especially the Mycobacterium avium intracellular complex, particularly in immunocompromised individuals.
Okay.
Then there's what we sometimes call atypical pneumonia, often milder. In the context of HIV/AIDS, you have to think about pulmonary Kaposi's sarcoma.
That's the cancer affecting the lungs.
Yes. Also, common viruses like flu or CMV infection. Less commonly, things like measles or varicella pneumonitis, Q fever, or rare bacterial infections like actinomycosis or nocardiosis.
Wow.
And even non-infectious things like lymphocytic interstitial pneumonia, linked to autoimmune disease, or even a pulmonary embolism, a blood clot.
That's a huge list. It really highlights why you can't just rely on symptoms alone.
Absolutely not. You need more definitive evidence.
So how do we get that definitive diagnosis then, if the differentials are so broad?
The gold standard is actually detecting the Pneumocystis jirovecii organism itself, or, parts of it, in respiratory samples.
Finding the bug itself.
Exactly. Finding its DNA or specific antigens, proteins in samples, coughed up or washed out from the lungs. We'll touch on how we get those samples when we talk investigations.
Okay, makes sense. Find the culprit. Let's zoom out again, epidemiology. Who gets PCP and where? Has the picture changed over time?
Well, as we keep saying, it's mainly people with weakened immune systems. Historically, HIV/AIDS with low CD4 counts was the dominant picture.
But that's changed.
Dramatically. The introduction of effective HIV treatment, HAART or ART, has massively reduced PCP incidence in that group. It's a huge public health success story.
So, is it rare now?
It's certainly much less common in HIV patients in places like the UK, thanks to good HIV care and preventative strategies. But, and this is important, it's still a very real concern for other immunocompromised groups.
Like the transplant patients, cancer patients?
Exactly. Transplant recipients on immunosuppressants, people with blood cancers, those groups are still significantly at risk.
What about globally?
Interestingly, reported rates might be lower in some developing countries. That could be due to several factors. Maybe lower survival rates for untreated HIV, potential underdiagnosis, or even other lung infections like TB being more common and maybe masking PCP.
So still a threat, just the populations most at risk have shifted somewhat in high-income countries.
Precisely. We can't become complacent, especially outside the HIV context.
Okay, let's get practical now. How does a patient with PCP actually present? What are the clinical features we'd expect to see?
Often, the onset is quite gradual, sort of insidious over days or even weeks.
Not usually sudden.
Not typically like a classic bacterial pneumonia, no. The most common things are progressive shortness of breath dyspnea and a dry, non-productive cough, meaning they're not coughing much stuff up.
Okay, shortness of breath, dry cough.
Fever is common too, along with significant fatigue or malaise. Some people report chest discomfort.
And if it's more severe?
You might see cyanosis, that bluish tinge to the skin from low oxygen and obvious difficulty breathing, using extra muscles, breathing fast.
What about listening to the chest? Auscultation.
That's the interesting thing. Often, there aren't many specific signs on chest examination, especially early on. The lungs might sound surprisingly clear relative to how breathless the patient feels.
A disconnect there. Any complications we might see presenting?
A pneumothorax, a collapsed lung, can happen. And although rare, maybe 1–2% of cases, the infection can spread outside the lungs, extrapulmonary PCP.
Where might that show up?
You can see enlarged liver and spleen, swollen lymph nodes, sometimes eye problems like choroid lesions.
So mostly lungs, but keep an eye out for rare spread. Any other clues?
Well, shortness of breath that gets worse with exertion. It's very typical. Rapid breathing, tachypnea. And of course, in someone with AIDS, look for other signs like thrush, oral hairy leukoplakia, Kaposi sarcoma lesions.
So that classic triad, progressive dyspnea, dry cough, fever, especially in someone immunocompromised, that should really make you think PCP.
Absolutely. That's the trigger to investigate further.
Right. So investigations, we suspect PCP. How do we confirm it? You mentioned finding the organism.
Yes, that's central. We need respiratory samples. The main ways are induced sputum, getting the patient to cough up deep lung secretions after breathing in salty mist,
Okay.
or doing a bronchoscopy and washing out a section of the lung. That's bronchoalveolar lavage, or BAL. Sometimes, rarely, a lung biopsy might be needed.
And what are we looking for in those samples?
We're looking for the Pneumocystis jirovecii DNA using PCR, or staining the sample to see the organism's cysts or active forms directly under the microscope.
Okay, direct detection. What about imaging? Chest X-ray, CT.
Imaging is vital. A chest X-ray is usually done first. It might show that classic pattern of diffuse, bilateral, interstitial shadowing, sort of hazy infiltrates in both lungs.
But not always.
No, crucially, the X-ray can look different or even be normal, especially early on. A CT scan, particularly high-resolution CT, HRCT, is more sensitive.
What does the CT typically show?
Often it shows what's called ground glass opacities, that hazy appearance again, often quite widespread. It can pick up changes the X-ray misses.
Any other tests that help? Blood tests?
Yes, some blood tests are supportive, though not diagnostic on their own. Lactate dehydrogenase, LDH levels, were often quite high in PCP.
LDH, okay.
Arterial blood gases, ABGs, are important to check oxygen levels. They'll often show hypoxia, low PaO2. And you might see a widened Ake-era gradient, the difference between oxygen in the alveoli and arteries, showing impaired gas exchange.
What about that exercise test?
Yes, exercise-induced desaturation. Sometimes checking oxygen saturation while the patient walks can show a significant drop, which is suggestive.
Anything else? There's something about beta-D-glucan.
Yes, serum 1-year beta-D-glucan is a fungal cell wall component. Levels can be raised in PCP, but also in other fungal infections, so it's not specific. It's being looked at more as a supportive marker. PCR on blood is sometimes used too, especially in HIV patients.
So it's a combination, really clinical suspicion, imaging, and ideally finding the organism in a respiratory sample.
That's the approach. Oh, and pulmonary function tests, PFTs, can sometimes help too.
How?
They might show reduced lung volumes, but the most consistent finding, and quite sensitive, is a reduced DLCO, the diffusing capacity for carbon monoxide, which measures gas transfer efficiency.
Right, reflecting that impaired gas exchange.
Okay.
Okay, we've got the diagnosis. How do we manage PCP?
First off, early diagnosis and starting treatment promptly is key. And remember to think about PCP even in non-HIV patients if they have risk factors.
Where do we treat them? Hospital? Home?
It depends on severity. Mild cases might sometimes be managed as outpatients, but moderate to severe PCP needs hospital admission, often for intravenous treatment. And it can take a little while to see improvement, maybe around a week.
What's the main drug treatment?
The first-line treatment, the go-to drug for mild to moderate PCP, is high-dose cotrimoxazole. That's trimethoprim sulfamethoxazole, or TMP-SMX.
Cotrimoxazole, okay.
It's very effective.
What if someone can't take it? Allergies or side effects?
There are alternatives. Atovaquone is one option, dapsone plus trimethoprim is another, or clindamycin combined with primaquine.
What about that inhaled drug, pentamidine?
Aerosolized pentamidine isn't generally favored for treatment because there's a higher risk of relapse compared to systemic therapy.
Okay, so cotrimoxazole is preferred. What about severe cases?
For severe PCP, it's usually intravenous cotrimoxazole or high-dose oral if they can take it. If that's not working or can't be used, then intravenous pentamidine becomes an important second-line option.
You hear about steroids being used too.
Yes, absolutely crucial. Corticosteroids are added to the treatment for moderate to severe PCP, especially in HIV-positive patients.
Why steroids?
They help dampen down the intense lung inflammation that the infection triggers. Studies show they reduce the risk of worsening respiratory failure and death in more severe cases.
So antifungal plus anti-inflammatory for severe disease.
Essentially, yes. We also need to be aware that rarely drug resistance can be an issue, but cotrimoxazole is still highly effective in most cases.
And how does HIV treatment RT fit in?
Starting or optimizing ART is crucial for HIV patients, as improving their immune function is key to long-term recovery and preventing recurrence. As we said, effective RT has drastically cut PCP rates.
Can people eventually stop taking preventative drugs if their immune system recovers on RT?
Yes. If someone's CD4 count stays reliably above 200 for a sustained period, usually several months, on effective ART, then stopping PCP prophylaxis is often recommended.
Speaking of prophylaxis, who needs it in the first place?
Prophylaxis, or preventative treatment, is really effective. It's generally given to people with a history of PCP, anyone severely immunocompromised for other reasons, and definitely HIV-positive individuals with a CD4 count below 200.
And what's the drug for prevention?
Again, oral cotrimoxazole is the preferred agent, usually taken daily or 3 times a week. It works very well.
Okay, so manage the acute episode, consider steroids if severe, and think about long-term prevention in high-risk groups, which might be stopped if immunity improves.
That's a good summary.
What about the overall outlook, the prognosis?
It really hinges on a few things: the patient's underlying immune status, how severe the PCP episode is, and how quickly treatment gets started.
So early treatment helps.
Massively. With prompt diagnosis and the right treatment, the prognosis is generally good these days.
But it can still be dangerous.
Oh, definitely. It can still be life-threatening, especially in someone with very advanced HIV/AIDS or profound immunosuppression from other causes. Severe cases requiring ICU care have a significantly higher mortality rate.
Right.
So while outcomes have improved hugely, particularly with ART for HIV patients, severe PCP remains a serious illness. We still see deaths, even in high-income countries, sometimes related to delays in diagnosis or access to care.
It underscores the need for vigilance. What are the main complications we worry about with PCP?
The big one is respiratory failure. The lungs just can't keep up with oxygen demands.
Okay.
Pneumothorax, the collapsed lung, is another significant complication. ARDS, acute respiratory distress syndrome, is a severe form of lung inflammation that can develop.
Nasty stuff. Anything else?
Patients are vulnerable to getting secondary bacterial infections on top of the PCP. Sometimes lung cysts can form. And as we mentioned, though rare, there's that risk of hematologic to spread the infection getting into the bloodstream and potentially seeding other organs like bone marrow, liver, spleen, lymph nodes, gut, even the eyes.
So quite a range of potential problems if things go wrong.
Yes, highlighting why getting on top of the infection quickly is so important.
Absolutely. Well, this has been incredibly thorough. To wrap it all up, what's the single most important takeaway message about PCP for our listeners?
I think the key is PCP is a serious but usually treatable lung infection in immunocompromised people. The cornerstone is thinking about it in the right context, the patient with weakened immunity and respiratory symptoms. Then, diagnosing it properly, usually with respiratory samples and imaging, and starting treatment, typically high-dose cotrimoxazole, promptly. And don't forget prevention for those at highest risk.
Great summary. Think of it, find it, treat it, prevent it. For everyone listening, if you want to cement this knowledge and explore more resources, definitely check out passthemsra.com.
That's PASSTHEMSRA.com.
And also freemsra.com.
FREEMSRA.com. Lots of helpful stuff there.
Yeah, really useful sites. As you review all this, try to connect the dots how the risk factors lead to the pathophysiology, which explains the symptoms and investigation findings and guides the management.
Exactly. Seeing those links really helps it stick.
And maybe a final thought to leave you with. We've seen amazing progress with PCP and HIV thanks to RT, but what are the big unanswered questions or challenges remaining for preventing and treating PCP in that growing population of non-HIV immunocompromised patients? The transplant recipients, those on biologics, cancer patients, where does the research need to go next?
That's a great question. Definitely food for thought.
Thanks for joining us for this deep dive into PCP.